Question, guys. The next question is BERA. They're talking about Brainstem Evoked Response Audiometry. That is nothing but ABR. Okay. Brainstem Evoked Response Audiometry, right? So this is the one they have asked. So basically this is coming under Evoked Response Audiometry. There are two things under Evoked Response Audiometry. ElectroCochleoGraphy. So this is from the cochlea and this is from the brainstem. Two things you can have. This is also an objective test. The person cannot lie. You will find out for yourself whether the person can hear or not. So it is going to give you the response from the cochlea or from the brainstem looks like. So here you have your cochlea. So you will check whether there is how the electric signals are from the cochlea, or also you can check from the brainstem, right? From the brainstem, what the response electrical signals are. So now let us look at this electrocochleography, which they have not asked in the exam anyways. Basically, this is the electrical potentials arising from the cochlea and the 8th cranial nerve, the vestibulocochlear nerve. And what they have shown here is the normal one, guys. So if you want, you can draw a nice graph like that. And this one where they are showing SP and AP. SP is smaller, AP is more. A is what? Action potential. What is SP, guys? Summating potential. Summating potential will be less than action potential in this proportion. But what happens in many years, the summating potential becomes more than what it should be in comparison to AP. Okay. It is not more than AP, but it is more than what it was before, right? This is Meniere's disease. Let's look at the actual question. Okay, auditory brainstem response. You will have to draw this graph. This is the response from your brainstem. So you know the auditory pathway. How does the signal go from the 8th nerve? From the 8th cranial nerve, guys, it goes to the cochlear nuclei, which is then medulla. They're showing, right? Then it's going to pons. In pons, you have superior olivary nucleus, lateral lemniscus. Then you have it going to the midbrain. Midbrain, you have two things they have mentioned here, inferior colliculus and medial geniculate body, and then the primary auditory cortex. So the electrical signal here you will measure. So draw this graph, guys. So this is from the distal part of 8th nerve. Okay. Which color do you want? This one. So from the distal part of 8th nerve, then the proximal part of 8th nerve, the cochlear nucleus, superior olivary nucleus. This is from the lateral lemniscus. This is from the inferior colliculus. Okay. So basically 8th nerve, the cochlear nucleus, the superior olivary nucleus, lateral lemniscus and inferior colliculus. So E. coli, if you remember, you will be able to draw this, right? So look at the graph here. How will you draw it, guys? 5 is the longest, tallest, stablest, most significant. This one, the 5th wave is very, very significant. And they are showing you the time duration. 1 to 3 is 2 millisecond. 1 to 3 is 2 millisecond. 1 to 5 is 4 millisecond. Will you be able to draw this graph, guys, in exam? Between 3 and 4 go down and 5 should be the highest, okay? 2 is a little high. 1, 2, 4 and 5 are kind of progressing in the same way. Like this you can draw. But only between 2 and 4 there is some dip. That is 3, okay? Here you have millisecond, guys. 1 millisecond they are showing here. And here they are showing you some potential, voltage, okay? Where will you use this, guys? This procedure you can use for children, for infants actually. Threshold of hearing in infants and children, and in adults who are, you think are lying in them also you can do this, right? Because it's an objective test. You can diagnose retrocochlear pathology behind the cochlea if there's any pathology. You can know if there's some brainstem pathology. You can know. Then basically when you're doing some surgery, you can monitor the 8th cranial nerve intraoperatively in surgery during acoustic neuroma to preserve the cochlear nerve.